Hello, and welcome to another Early Years Learning Hub podcast. My name is Jackie Ward, and I'm the founder and managing director of the Early Years Learning Hub. This podcast is part of our series titled Practice Sharing, and today it's a little bit different because it's not a teacher, educator, or leader in early childhood, but we're actually speaking with Stephanie Eber, who is a speech therapist from Inner West Pediatrics, about what a speech therapist does, recognizing typical, speech development, and what do you do if you notice some atypical developments. So I'm going to hand over to you. Thank you so much, Stephanie, for joining us. Would you like to tell us a little bit about our listeners, a little bit about yourself?
Sure. Thanks for having me on the podcast, Jackie. I've been a speech pathologist for about 20 years now, and
Mm.
I started in the profession because I went to a speech pathologist when I was 4. I couldn't say the S sound properly. And I just remember it was really fun. I played games the whole time and I got to make up fun sentences. So when I went to exploring careers, I thought, you know what, that was really fun having that experience. I'd like a job where I can have fun and play games all the time. So speech pathology just seemed like the right profession for me. Since then, I have worked in a number of different, mostly pediatric settings. So I've worked in hospitals, community health centres, non-government organisations in community outreach positions, private practice, and I've actually just returned from spending 11 years in Hong Kong working as a speech pathologist at an international school and then in private practice over there as well. So I've done a few different things in my career, but that's what I love about speech pathology. It's such a diverse field, and when you constantly change your caseload or change where you work, it feels like you've had a whole career change, which is really nice.
That sounds amazing. And I can't believe you've been a speech therapist for 20 years. You look like a baby.
Thank you. That's very flattering.
But yeah, I love that. And I always ask this question because I love our listeners to hear a little bit about how people's journey as, career paths have gone in different directions. And I feel very fortunate to have, when I've done some shifts and changes. And it's interesting to see where everyone lands. And also I think that really contributes to your confidence and your enjoyment of your profession if you've done a few different roles too. So that's amazing.
Definitely. Definitely.
So
And I
glad
think
that
that
you
there's,
found a passion.
yes, thank you. And I feel like with teachers, when you're continuously learning and honing in on your skills and you're constantly exposing yourself to different things. And that's just great because it keeps it interesting.
Yeah, definitely. So, one of the reasons why I was really keen to have you on the podcast is because I guess it's always been a challenge. If you're a teacher, your area, or an educator, your area of specialty is usually teaching and typical behavior and all that kind of stuff. And I recently had a professional learning with yourself and Lucy, who we'll also have on the podcast, an occupational therapist. And I was really fascinated to hear more about what you guys do. And I think it'd be really helpful for our listeners to really understand, what does speech therapy involve? What are you looking on? What are you working on? And how can we work together to support each other, to support children and families, basically? So I guess I'm interested, speech and communication. What exactly does a speech therapist support with? What's your sort of main role?
Okay, so it's a very broad field. People who graduate tend to go into adults or pediatrics, or they may have a mixed role. I've done a little bit of adult work, but predominantly pediatrics. So in our field, we typically see kids with either speech delays or disorders, language delays or disorders, fluency, so stuttering and disfluent speech, voice disorders, so the kids who are a little bit husky or they sound a little bit strained or strangled, eating and drinking. So at the moment, I have lots of kids who I'm working with who are fussy eaters. So they might have a disability or they might just have very strong preferences for what they want to eat. Speeches are also working in the literacy field, so working with kids who are struggling a bit with their reading and writing, and also moving more and more into oromotor disorders, so kids who have weaker muscles in their mouth and tongue, which could be caused by oral habits like thumb sucking for a long time or extended bottle use, or tongue ties. So the tongue is quite restricted inside their mouth, or they might have an airway problem. So they're having to breathe with their mouth and not their nose. So working with those clients more and more as well. Every client who comes into the office is quite different, which is great. And we have to ask the right questions and do the right assessments to figure out what's happening with this child, what's potentially causing it, and what the best way is of treating this client in the inappropriate team-based setting as well.
That is amazing. I would never picked that broad range of things, especially the eating disorder, well, not disorders, but eating issues and things. I wouldn't have picked that as well. I am interested to ask you a little bit about the difference, I guess, because you mentioned speech issues and language issues. What's
Mhm.
the difference between those two?
So speech issues is how you pronounce the words. So it's articulation. So if the sounds in the words are spoken correctly, that would be a speech uh, issue if they're not spoken correctly. Language is more about the words and the sentences that a person uses and understands. So I know it can be a bit confusing. A lot of people will use the words interchangeably, but if they have a speech disorder, the pronunciation, if you have a language disorder, it's you're not using enough words or the right words, or you're struggling to express yourself coherently because you can't get your message across correctly. Some kids will have
Mm.
delays in both speech and language. Other kids will have a delay in either speech or language.
Well, that's interesting enough in itself.
Yeah.
That's amazing. I hope that really helps our listeners to kind of understand what they might be seeing when they're seeing those kind of behaviors. So
Mm.
I'm interested to sort of get your thoughts on, we might, our audience might be, the birth to 5, or it might even be, into the early years of primary school. And I know there's a lot of detail that you could put into this, but just a high level, what's an overview of typical speech and language development that you would expect to sort of see? And you can go into as much or as little detail as you like there.
Sure. So in the 0 to 1 age group, so babies, we'd be looking for things early on which helps to support language development. So we'd be looking for children who are responding to voices and responding to facial expressions. And we should see that pretty early on with babies. So them
Mm.
smiling when they see their caregiver, or copying some facial expressions that the carer might do. The back and forth movement and imitation is really important. We're also looking for joint and shared attention. So we're looking for babies who are looking at a toy, looking at their caregiver, looking back at the toy when they want something, and being focused on an activity with their carer and having some interaction with them. So whether it's looking at back and forth or passing things to somebody else, so interacting in a meaningful way. We'd be looking for gesture use, so waving, clapping, responding to their name and other keywords that they might be exposed to. So we're expecting those things to happen before a child starts one. Babbling generally starts at around 6 months of age and gets more varied into the more 9 months of age phase. One is typically when kids start to develop their first words, and then by the time they're 18 months, they often have 6 to 20 words. There's a bit of variation there. When they're 2, they will often have 50 words in their vocabulary, and that's when they start to put words together. So generally, when you have 50 words that you can use, that's when you can start to join them and link them to add a bit of complexity to their language. And then it keeps building from there. And so at 3 years of age, they're often using 4 to 5 words in a sentence. And 4, they're continuing this onwards and using connecting words to link those ideas together. With their speech development, obviously you need your language to develop before your speech develops. So you practice using those words. When you're around 2 years of age, it's pretty common to understand about 50% of what a 2-year-old says. So their speech there's a lot of speech sounds that haven't come through yet. But then as they get a little bit older, by 3, you're understanding more and more of what they're saying. And by the time a student starts school, they should have most of their speech sounds already developed and present in their vocabulary. The exceptions are the TH sound. Sometimes the TH sound is not clear. It might be an F for a TH, and that's pretty typical until a child is maybe 7 years of age. Sometimes the R sound hasn't come through by the time they start school, but in most cases it has, or it's starting to be, it should be there by the time they're around 5. And then we're also looking for things that happen that that assist to develop the oral muscles for a child to be able to speak properly. So I'm looking at oral habits. So with children who are sucking their thumbs, using a dummy and using a bottle, we're hoping that those things are all done before they're all finished before a child starts school, because they can impact how the face grows and develops as well. We obviously, speech pathologists often don't like dummies unless you need it for particular circumstances. such as premature baby or a baby that has problems with sucking, then that might be a recommended strategy. Ideally, we hope that dummy use is the easiest time to get rid of it is when the child is 6 months of age. After that, it gets a little bit trickier. But again, with everything, we're hoping to phase all those habits out before the damages is kind of the structural changes start to happen.
Not to mention issues with teeth too, especially if you're having a bottle and going to sleep, tooth decay and all that kind of stuff.
It's
Well, that
all linked
is,
together.
yeah, very fascinating. And I remember now too that you also shared with us, I forget the name of the website. Was it Communication Australia? You shared with us some developmental sort of checklists, or not checklists, but sort of what to expect at different ages. So I'll make sure I pop that in the links as well. So that was really handy as well.
That's great. That's, yeah, through Speech Pathology Australia. They
Yeah,
have
that
great
was great.
sheets
Yeah.
and posters that you
Because
can pin
again,
up and
I
put
think
it in your room.
it's just good to know because I remember thinking, and as our listeners might be able to tell, I've had lots of years of experience. So it's not like I haven't been doing this a long time, but what it feels to me like when you get to a point where you're worried or concerned about something, you forget all the stuff that you already know. So it's good to have a sort of I guess an objective thing that's, put out by a recognised authority, Speech Pathology Australia, to have a chat with families. This is what I'm seeing that doesn't sort of align with typical development. So that is awesome. Thank you. So what about recognising atypical development? So what are the things that you're seeing in your practice? I know you've already mentioned them. We've talked a bit about those sorts of things, but what would be some other really, really common things that you'd see, and what ages do you normally see? What age do people bring children to you, I guess?
Typically, kids start coming around the 2 years of age when they are either not talking or they're not talking very much. So sometimes we have some kids who are coming from 18 months, but quite often it's 2 when parents start to become concerned. And then I would say most of my caseload would be aged between 2 and 7. That's
Mm,
when we typically do the most work with the kids. So it's really common. 1 in 5 kids start school with a speech and language disorder in Australia. So that's a really high percentage. And I think we typically don't notice it because we become normalized to speech and language delays. It just so many kids tend to have them and we don't notice them so much. So like I said, it's helpful knowing the norms so you can look out for them. So that's, yeah, huge percentage. So a lot of these kids we will see will have problems following instructions. A lot of kids who tend to copy other kids in the classroom because they find it hard to both hear, process an instruction, and then follow through with it. So problems, yeah, with instructions and directions, and also following the classroom conversation. Kids who don't have enough words, so little kids who are a bit slow about their words, or when their words come through, they're struggling to link their words fluidly. So when they're talking to you, they seem to keep talking and talking and talking, or they talk around in circles and they find it hard to get to the point. And that might be because they don't have the vocabulary that allows them to use the right words to express
mm,
themselves and get to that point clearer. I see a lot of lisps. I notice a lot of lisps around me. So lisps are the S sound, and it can happen with other sounds too. So that's when your tongue pushes forward, either against your teeth or between your teeth. So it pokes out when you're saying any words with S. I'm noticing that a lot, especially with 4 and 5-year-olds. And that can be caused by oral habits. So if you're thumb sucking for a long time, or your finger sucking, or using a dummy for a long time, your tongue gets used to going forward and back, forward and
mm,
back, forward and back. And that typically continues. And then when their children are speaking, their tongue tends to go forward and back as well, which means that their speech isn't as clear as what it could be. So we need to work on them having their tongue in the correct position. So lisps are coming through, as well as a whole range of different speech sound disorders. What else? I see a lot of kids who, like I mentioned before, weak oral muscles, because there's a lot of kids who do have blocked noses. So they have their
mm.
adenoids are enlarged, or they have allergies. They're finding it really hard to breathe through their nose. So they're breathing through their mouth. And when you breathe through your mouth, typically your tongue isn't resting in the right position. We want your tongue to be on your hard palate, either touching the top teeth or just a few millimeters, it's touching a little bit behind on your hard palate. Your teeth should be touching or a few millimeters apart, and your lips should be closed. and you should be breathing through your nose. And when that happens, then your face grows how it's meant to grow. Your hard palate is nice and wide. Your teeth have enough space. They should have nice little gaps in between your teeth so that when your baby teeth fall out, there's enough space for all the adult teeth to come in so they don't come in all crooked and crowded. When children have their mouths open, their tongue isn't against their hard palate, which means
Mm.
the hard palate doesn't have the tongue keeping it nice and round and wide. Their hard palate tends to get a little bit more narrow and more kind of triangular, which means that their tongue's resting in the bottom part of their mouth. They're more likely to have their tongue moving back and forth when they're talking. Their teeth are more likely to come in crooked when the adult teeth come in. And they're more likely to get sick as well because they're not having the air being filtered through their nose. And their face ends up growing quite narrow and long, so not how it's developmentally meant to be genetically growing. So there's repercussions with that as well. So we often refer to an ear, nose, and throat doctor and refer for early dentistry work as well and manage the speech side of things with that, so help to correct those speech sounds. And additionally, teach the child once they can breathe through their nose, once they've had that intervention from a medical professional, teach them where to put their tongue and how to get their lips closed and build up the strength of those oral muscles if they need to. So that's something that I work with a lot, and I see kids often from the age of 3, but typically 4, 5, 6, 7, 8, 9-year-olds are coming through for that treatment, or kids that are going through orthodontic treatment and their tongue is thrusting back and forth, and that's going to mean that they're not going to get a lot of success with their orthodontic treatment, or they might get success now, but then if you don't correct the tongue behavior, then down the track, they're going to undo all that hard work that the braces or the retainers did because they're going to start pushing their front teeth forward. So I do see a number of teenagers to help teach their tongue to be in the correct position to make their orthodontic treatment more successful. So that's a thing. But like I mentioned before, the fussy eaters, see a lot of that, or kids that have problems chewing, or their jaw isn't particularly strong, so they get very tired, or they might have a tongue tie in their mouth, which makes eating more difficult because they can't move their tongue around as much, and they might be bloated and gassy because they are inhaling more air through their mouth when they're eating and drinking. So they might have stomach aches and bloating. And also they might not sleep particularly well in the nighttime because when you have your mouth, if you have a tongue tie or a nasal obstruction like enlarged adenoids or allergies, and you're breathing through your mouth, you're doing that at nighttime as well. And when you breathe through your mouth, you don't get that same quality sleep that you get if you were nose breathing. And even though kids might sleep 12 hours in the nighttime or 11 hours, whatever they're doing, the quality isn't the same. So they tend to be more tired in the morning. They have dark circles under their eyes. They often are characterized as the naughty child in the classroom because they can't sit for long periods. They can't concentrate because they're really tired. And we just don't know
Mm.
that. So I'm always looking out for those things as well and referring to the right people and helping them with the rehabilitation around that process if we need be, because we want kids to be well rested and be able to focus in the classroom. And that's one thing I really want to hone in about. If you're noticing a child who is breathing through their mouth, or parents report they're grinding their teeth at night or they're snoring, then they need to go and see a ear, nose, and throat doctor straight away to try and address those issues.
Fascinating, absolutely fascinating. I was thinking when you were just talking then and that it would be great for educators and teachers if they were having troubles with any family members to send them this podcast along so they can really understand why it's so beneficial. Because all of what you've talked about, if they don't get these speech issues addressed now, that's going to have a big impact throughout their whole schooling, isn't it? So you're really setting children up for success if you get these issues sorted in that early childhood phase. Like most things, early intervention is a great thing. So the earlier you can get onto things, the better. But yeah,
100%.
awesome. Very fascinating. So, some key information. What are some of the things? So, now thinking about me as a teacher and educator, what are some of the things that you find helpful if families or early childhood services share with you? What helps give you a good picture of what's going on with the child?
So I like to know the history of it. So what's been happening from birth, basically. So when I do meet with a family, I want to know about their eating and drinking history from when they were born, so the breastfeeding history, because that can, and the bottle feeding history, because that can tell me about their oral motor development. In school, I want to know about what they're like in the classroom. Can they sit for long periods of time? Do they have to get up and have lots of breaks? What's your alertness level like in the classroom? I'm interested to see how they're following instructions, do they copy other children, just from what you're seeing day to day, because like sometimes kids can be quite different in the classroom versus at home. They might mask
Mm.
their behaviors and be better behaved in the classroom, and they might get in the car and have a massive meltdown because they've been holding it in all day, or they've been masking, like hiding the true difficulties that they're actually having. I like hearing about it from different perspectives. I like to know if they have had a screening done before at school or at preschool and anything has been picked up, or when these concerns arose, because like I said, 1 in 5 preschoolers are starting school with a speech or language delay. A lot of speech pathologists now go out to early intervention, go out to preschools, go out to kindergarten. I know a number of schools have asked us to
Mm.
come out to screen their kindergarten kids so we can start to pick up on anything that's going on when they are starting school or before they start school, so we can work with them straight away and try and help them to get over whatever issues they're having. So I like to know about if that has happened. And also, if anyone else has been involved, I'd like to know if the child has seen an ear, nose, and throat doctor, if they have a dentist already involved with them, which they should, if they've had a previous speech assessment or any other allied health professional assessment, if they've had any tongue tie releases done previously. Also, yeah, if there's any family history of any speech and language issues, which can help us to kind of understand the history of the family and where the family what they have experienced, and some conditions can have a genetic link, so it helps us to understand them a little bit more as well.
That's a lot of information, isn't it? And I guess most of that would probably come from the family. But I guess my message here is, as an early childhood teacher, I now understand better that I needed to provide more information. If I'm going to raise a concern with a family member, I need to provide the context of why it's a concern. I've noticed this. I've noticed this on multiple occasions. It's in these situations that I've observed the child doing X, Y, and Z. So all of that information the family can then take on to, a speech therapist like yourself to get a better understanding of what's happening. That is
Definitely, because
awesome.
like I said before, parents become normalized to their child's behavior because they're seeing it, their child's language, speech and language, because they're seeing that all the time. And if a child is not pronouncing a word properly, that's just how the child has always been, probably. And they often don't see other children or notice it in other children. So they're not really aware that maybe it's not normal. So they really need to know that from a early childcare teacher or a preschool teacher or a school teacher, because often they're just not aware. Like I have mentioned it, I find it really hard when I'm in social settings when I see kids who do have speech and language issues, because it's not my place to say it because I don't have a relationship with these people, but I really want to. But I have occasionally with people that I'm friends with, and they've always been so surprised when I've said, "Do you realize your child has a lisp?" And they'll say, "Really?" And they have no idea, because as parents, we know our child so well, but we don't compare them as much to other kids. We don't notice it. So it's helpful if you are seeing it. And I understand that it can be a difficult conversation to bring that up with
Yeah.
parents. So it can be good to find out if they've noticed, ask them if they've noticed particular things, or if they have any concerns about this, and see if they can bring it up in that conversation with you. And then you can share your point of view and what you've noticed in the classroom as well.
I loved what you said about that. That idea of asking families, I've noticed this. Have you had any experience with this? What are your thoughts on that? And then also when you first raise the issue, being prepared with those other documents, like the typical development from Speech Pathology Australia, or all of your observations and whatnot. So you've got some information at hand, but not necessarily putting all that up front, but just having a nice, easing conversation with families. How they going? What have you noticed at home? Is there anything you're concerned about? And I think that's a nice way to bring it up first, because it's also that idea of building nice relationships first, isn't it? And then after that, you can bring it up. But yeah, I've had a lot of that, Stephanie, where people just randomly ask me something when I don't know the person and I don't know the child very well. I mean, I might still know what's going on there, but I'm always like, oh, this is really awky for you to ask me that right in randomly without knowing anyone. And you're like, well, how can I answer this without hurting anyone's feelings? And the other thing I think too with little kids is that people often think their way of speaking is just cute. You know what I mean? Like it's cute when they've got a little bit of a speech issue. So, yeah, that's fascinating and so very helpful. So, supports and strategies. What are some common supports that you would provide? Obviously, I'm not suggesting we could, in lieu of a speech therapist, but what are some of the things, I guess, if an early childhood teacher and educator noticed some things, what were some of the things that you normally work with? Or let's say a child in our service has gone to a speechy, and I've had this a million times, and I've asked the families to share some information about it, and they sort of just end up sharing very little information or something without any context of, oh, they're supposed to do these exercises, and I'm like, well, I'm trying to do them, but I don't really know what they are. So what are some of the, I guess, can you shed any light on that for us?
Sure. I mean, if you can contact this, if you can get the details of the speech therapist and contact them directly, we always love
Yeah.
hearing from the teachers because we know that families are busy and teachers are with the kids a lot of the time as well. So we're always happy to share what happens. So you can reach out to the speech pathologist and they're generally more than happy to share on their suggestions. And often when we do see kids, we will send an email to the family after every session. So even if the family have come to the office, we'll still send an email to the parent just reiterating what we did. And we can always include the teacher on that email so they are completely involved in the process if they're welcome to. So if you can ask the family if that happens and if you can get included, that's a great way of seeing the strategies that happen. You could speak
Mm.
to the parents to ask if they'd be open to having a session in the preschool or in the schools, and you can observe. And depending on, I guess, it's also things you got to think about, like the funding, the money, the financial side of things. But in an ideal world, that's a lovely thing that we can do because then you can see what we do with the child and we can talk through strategies that we're doing in sessions with you so then you can follow through them in the everyday life with you. I mean, facial language is I guess there's different strategies with kids who are a bit slower to talk or they're struggling with their language skills. Then just breaking language down for them. So when you're giving an instruction, if you notice that a child doesn't seem to be really understanding what's happening or they're looking at or copying, go up to them and say, break it down. So, okay, first I want you to do this. What are you going to do? And get them to repeat it back to you. And then when they come back, okay, great, well done. Now, next, you have to do this. So you're giving them one step at a time instead of giving them 2 or 3 steps. So really just keeping it simple and checking in with them that they're understanding. So if you're having a conversation about a book, then you can read a story and then reiterate it. So simplify, summarize it back to all the children. So you have a complex version, then you have a summary of it. And then you can just check in. So ask the right questions, ask them simple questions, check that they've understood what you have said. And it doesn't have to be in a whole class setting. If you don't want to draw attention to it, after everyone's gone to the next activity, go to the children they're struggling a little bit and say, do you understand what's happening? What happened to the piggy? Where did she go? Wow, how do you think you felt? Asking some questions, check they're understanding what you said. Having pictures around the classroom, visuals is really helpful. So if you have some pictures of activities they could be doing in the classroom, that'll help with them to make choices and to communicate things that maybe they're struggling to explain. When you are doing any written work in the classroom, make sure everything has a picture or use diagrams or anything visual so you're providing them with the verbal and then you also provide them with the visual. So that helps them to support their understanding and they can point to things and show you things rather than trying to explain them as well. Even a child who has a speech delay, every child is going to be different, but typically when they are coming into a speech pathology session, we're doing lots and lots and lots of practice within that session to practice that speech sound and getting it producing it in the correct way. So we do high practice, and then the family are typically asked to do a little bit of practice every day to continue that. So the family may ask you to do some additional practice at school. It can be challenging because you have a whole class full of children, so you can't always allow for that individual time. But if it's getting to the stage where they can do the sound really well, it's just you're trying to generalize it to conversational speech, well, that could be a time where you could be listening out for that speech sound that if you're aware what they're practicing and just ask them, like if you hear them say it incorrectly, you might say, what did you say? I'll say that again. You might ask them back a little bit as well. And just a really good strategy I love to do is just when somebody says something incorrectly, whether it's the wrong word or the wrong verb tense or anything, just repeat it back in the correct way. So if someone said, I go to the zoo yesterday, just repeat it back. Oh, you went to the zoo yesterday. So you're just repeating it back in the correct way. And that over time helps the child to learn that correct structure or the correct word or sentence structure. But you're not putting pressure on them. You're not asking them to repeat you. You're just doing it really naturally in conversation and they're hearing the correct model as well. So they're just great strategies.
Mm.
Like you mentioned before, if you're noticing things, linking them with the right people as well. So if you're noticing that the child is mouth breathing, you can ask if they have seen an ENT about that. If you think that they're having some problems with um, writing, you might refer to an OT. If you have seeing speech language concern, you might help the parent to print out a list of local speech pathologists and the university clinics, which do have some subsidized services as well. If you can give them that information, that will also help them. And if you're noticing you have a few concerns with a few kids, it might not be a bad idea to ask a speech pathologist to come out and screen the kids in your center so you really know if you should be concerned, if the parent should be concerned. And lastly, shops like what we did at your
Mm.
preschool, asking a speech pathologist, they can come out and just talk to you and answer any questions you have or talk about the norms or even look at some kids while they're there to give their opinions, then that's a great way of upskilling yourself so you know exactly what to look for and you're helping to get the kids identified who need a little bit of extra support.
That's amazing. That's super helpful. I love that, even just that simple one of being CC'd on the email. I'm thinking I've got a little boy that I recommended to go to speech therapy, and mum and dad never said anything. So I and they'd been away and I'd been away. So I assumed that they didn't go. But mum told me last week that he had been going. And so I'm interested to hear how he's going. And that again, you may not do all of those things, but it's just good to be aware of what's happening, that you could reinforce that when it's appropriate and if possible, and it can also then be part
Mm.
of your assessment and planning cycle within your own individual records that you need to keep as a teacher and an educator. So that's really helpful. Well, that is amazing, Stephanie. Thank you so much. And I just wanted to let our listeners know that I will pop in the link also to Inner West Pediatrics. Is that, so have I said it right? Inner West Pediatrics?
Yes, you have.
Yeah, that's where
Yes.
Stephanie works. So obviously only applicable if you're in Sydney, but I will put it in there if you're interested to hear more. And also the Early Years Learning Hub has a really great course as well, which is called Strategies for Identifying, Communicating, Planning and Reporting for children with additional needs. And a lot of that, what we've talked about today about, identifying and putting together some information, having, respectful conversations with families, sharing, meaningful information with health professionals, and then planning for what you need to do. So I'll put the link to that course in our notes as well. Thank you so much, Stephanie, for joining us. I really appreciate you sharing all your wisdom and your time with us.
No worries. Thanks for including me.